All right, everybody, thanks for joining today. This is the STS National Database monthly webinar for April. On the phone with me from STS, we have Emily, Leanne, Banu, Melinda, Paul, and Sydney. And we are going to do what they say can't get done today on our call. So thanks for joining. And just a few STS updates, and then we'll get to Frailty, because I know everybody is anxiously awaiting the update on Frailty. And where is everything at? So April training manual has been posted. Harvest 1 closed on February 23rd. The data is back from analysis and it's being reviewed. We're hoping to have the results posted out to sites within the next 2 weeks, but we still want to review a few more things before posting it. And then Harvest 2 closes on May 24th. And so be sure to get your Harvest 2 data in well in advance, and that will be OR dates through March 31st, 2024. Frailty collection started on April 1st. Haha, just kidding. April Fools, everybody. No, seriously, we were hoping to go April 1st, but because of all your wonderful feedback from the webinar we had mid-March, we did some pretty extensive review with the feedback and made some updates. We're still working through those updates. Hope to go live mid-April, very, very early, very, very latest, I think will be May. There are a few things. So I do want to say thank you for all that feedback. Without it, we would have went live and not had a superior product. That's why it's so important to be inclusive in the decisions we make at STS when it comes to the data, and make sure that we're taking into consideration how it impacts our participants, our sites, and those that are using it on your end. So thank you for that feedback, and I apologize for the delay in going live, but we want to make sure we have it right. And with your feedback, I think we're there. So we're going to go through the data collection form and training manual to show you the changes we made related to the update you gave us 2 weeks ago. So March 3rd, that's today, ACSD monthly webinar, which is happening now. Quality Improvement Series, April 17th. Hope to have some final forms, or the forms are final for the Frailty, but I hope we're able to announce that we started collecting data by this time. April to May, that's when the soft launch will start for the Frailty data collection. We have a monthly webinar May 1st. ACSD Harvest 2 closes on May 24th. Opt-out is May 28th for Harvest 2. Quality Improvement Series webinar on May 15th, and then the Frailty mandatory date, I just built it out to January 1st, 2025. Of course, there will be a lot of other things happening between May 15th and January 1st, but just to give you an idea of what the timeline looks at specifically regarding Frailty. This May 15th webinar, hoping we're already going live with Frailty. I would like to present the Harvest 1 data for I would like to present the Harvest 1 data on our prolonged ventilation, or decreasing vent times, and increasing OR extubation or short ventilation times, how we're doing using the Harvest 1 data during this May 15th webinar, but more information to come on that. And then we're going to shift gears a little bit going towards blood usage. So if you have done any projects at your hospital on decreasing blood usage intra and post-operatively, or if you have done anything that includes patient optimization pre-operatively regarding to decrease the rate of blood that they would get intra or post-op, please reach out to me and share your projects with me, and I would love to have you present starting likely in June or July for that topic. So moving on, Harvest 2 2024, Harvest 2 again closes May 24th, opt-outs May 28th. All right, Frailty data collection and training manual. So where are we at and what's going on? So these are the things that we have kind of working through the last 2 weeks since we last met. I think that it might have even been less than 2 weeks ago. Hold on. Let me check my calendar. When did we last meet? That was, it was 2 weeks ago. Yeah, thanks, Melinda. On the 20th. So since March 20th, the last time we had a webinar, Melinda and I, Nikki, who is with our research center, Nikki is over the building our REDCap form for us. Paul Meehan, who is building out the data specifications, and Banu Yaxi, who is helping us with the working with this working group of surgeons that have been put together. We took all of your feedback from the March 20th webinar, have been working to update the forms. So that's where we're at with the data collection form and training manual. I believe we have a final data collection form, which you'll review today. Hopefully the feedback is positive and not too many other things are noted. And then the training manual is pretty much done, and Melinda's going to go through that for us too. Going back up to the top here, the notification to data managers and surgeons. I am working on sending a formal notification to data managers and surgeons. I hope to have that sent out within hopefully the next week. I have to get leadership approval before sending it out, so it takes a little bit of time to get it sent out to all of our surgeon leaders for their review. And okay, so as soon as I have that letter drafted in a pretty close to good format, a great format, I'll send it to the surgeon leaders. They'll approve it, provide some minimal feedback, and then I'll get it sent out to you all and to your surgeons. And then we are planning a surgeon webinar. I was hoping to have this date scheduled prior to sending out the notification so that it could be linked to right in that email. But right now I don't have a date scheduled for that. So I'm still waiting on that. Clinical screening worksheet and clinical training material. Due to version control issues with the data collection form updates that came out of the March 20th webinar, Melinda and I decided to hold off on making any updates to the clinical screening worksheet and training materials. So these would be the ones that are used at bedside or that are used to build it into your EHRs as smart phrases and things like that. We decided to hold off on this until we have a final data collection and training manual signed, sealed, and approved. And so we don't have too many different versions going around of different forms, because that can get messy and that's how errors happen. So we're just waiting for this webinar, one more review with you all, and then we'll finish up the screening worksheets and training material. REDCap and data specifications have been finalized according to the current data collection form. And we're good to go with that after this webinar. Hopefully everything will be finalized and we can get it posted early next week. I don't see any reason to hold off on it. Melinda, do you? If we
not unless we get some significant feedback
okay
to address.
Yeah. And thank you, I agree. And then the smart phrases, waiting for Dr. Weiler von Baumel. He'll be providing those to us to share with the sites. And they might not be available, right? He might not have all of this information right away, but we'll be adding it in as we go along. All right. Melinda, what do you want me to do now? Go to the
I think we should go to the either way. We can start with the training manual and put them side by side, however you want to do it.
Okay, I don't have the training manual. You have the training manual. So do you want to? Oh, you did?
I sent it to you. Yeah.
Oh boy. All right, hold on, everybody.
Never mind. I mean, if you want me to pull it up, I'll pull it up.
No, it's okay. Let me find it. So here's the data collection form, and I know everybody likes to take pictures, so we'll go. Let me find Melinda's email. You know what happened, Melinda, is I put my email in alphabetical order so I could try to get through. And your name's down towards the
way at the bottom.
Yeah, you're an O, so sorry. But I have
all right.
So I have hold on one second. Oh, actually, I don't have it.
Okay, so why don't we start with this, and then I can share my screen when we get to the training manual.
Okay, that's fine. Does that sound okay for everybody?
Yeah.
All right. So let me make this guy a little bit bigger.
Okay.
Hey, Melinda, why don't you go through I'll introduce the fields, and then maybe you could provide what the training manual says. Okay.
That's what I was thinking.
That way we'll do it in tag team. First question is going to be indicate how the patient rates their own L. So again, this
That's,
is the.
Carol, that's actually page 2, dear.
I was doesn't look right. Where did our other fields go? I'm like, I don't remember doing all those changes. Okay, whew. Sorry, everybody. Dear Lord. All right, restart. So first page. First four questions are the patient information. This is going to be covered from your vendor software. So Melinda, we have participant ID, record identifier, patient identifier, and date of surgery. Please go ahead
Right.
and take it from here for these four fields.
So the important thing is it's the same participant ID as your site is right now. Okay. And the patient identifier is like, your patient ID. So that's that V number. Okay. And then the record identifier is the record ID, just like you have in the normal database. And then, of course, the date of surgery is the date of the index procedure, just like you would have in the regular database.
Melinda, this is
Mhm.
Paul. Can
Yeah.
can we take this opportunity to stress
Yes, please, Paul.
heavily, stress
Please, Paul.
heavily with
You
all
want to
of
add
the,
that in?
yeah, please, with all of the supplemental forms, your patient ID and your record ID should start with the letter V for vendor. Okay, it's a value that's created by your vendor. And without that correct value, we can't link your data to the clinical data. And we have lots of people using the wrong identifiers. You have like 6 or 7 identifiers for your patients, and we're finding people that are using the wrong ones. So the rule of thumb, patient ID, record ID should always start with a V. So
Always
back to
start
you,
with a
Melinda.
V.
Yeah.
Good job. Okay.
So the next question is actually a new question that we added in. Patient was urgent, emergent, or emergent salvage, and had no family available, and they were unable to answer the questionnaire prior to discharge. So we added this field in because you guys brought up some really good points about what if the patient dies, or the patient dies in the OR, or if the patient has a stroke and they never wake up and they can't answer these questions and there's no family. So this is like a 2-part thing. So, or actually it's a 3-part thing. You got to be urgent, emergent, or emergent salvage. That's part 1. Number 2 is you got to have no family available at all. And then number 3 is, and then the patient can't wake up and answer the question either. So this is a patient that is unable to answer any of these questions, and there's no family there to answer the questions, and they were urgent, emergent, or emergent salvage. Then you can say yes if all of those things qualify. And when you say yes, all of the next several questions that we're going to go through will gray out, and they won't be required to be answered. Okay, so we added that field in based on your feedback from the last call.
Okay. Thank you, Melinda. So those the 3 requirements have to be met. Patient was urgent, emergent, or emergent salvage, and the patient had no family available and was unable to answer the frailty questionnaire prior to discharge. So we are not just excluding urgent, emergent, or emergent salvage cases. It has to meet these other 2 requirements to be the code yes to this field.
And Carol, maybe we should add this in here now. We talked
I
about
was
this.
wondering about, yeah, go ahead.
I was going to say that, eventually this will go into the risk model. Eventually, there's no plans right now. So it is important if you can, when you have patients with these statuses, it is important to get these questions answered prior to discharge, if at all possible. So just don't look at this field as, oh, well, I can just check this field because they were urgent, emergent, or emergent salvage. So it will impact the risk model eventually, not anytime soon. So keep that in mind.
Yeah, and you don't want to lose, that's a good point, Melinda. You don't want to lose the risks that will be associated with this patient's frailty status. These patients, probably the ones that are urgent or emergent that are very sick, they may have probably likely that they're going to have a more frail status going prior to the surgery anyway. Their normal status is probably more frail than an average patient. Most times I would think, I would say, um, outside of your cardiac arrest that happens at the gym, some of these patients are probably going to be more frail than others. So you don't want to lose that risk of the patient. So if you're able to collect the data for these patients on the frail assessment, you're going to want to, so that your expected rates for risk adjustment uh, take their status into account and consider their status when calculating their expected rates. And if these patients end up doing well, you don't want to lose that too, because then their expected rate will be, or their observed rate is going to be better than their expected rate. Usually when we look at frailty status of urgent, emergent, or emergent salvage, patient comes out of the OR, does really well. You don't want to lose that for your risk assessment, risk adjustment either. So very important to still collect it if you're able to. Next one, Melinda.
Okay,
So
so then,
go ahead.
go ahead.
I just say, if you answer no above,
Mhm.
then these next set of fields questions will open. And I know the question that's going to come out, well, is this expected to be filled out on every patient? And the answer is yes, that even if this patient is urgent, emergent, salvage, and has no family available and is unable to answer the frailty question prior to discharge, and you know that you're going to code yes here and that none of these other questions are going to open, we still want you to complete this at least first question, because this is what we could look at for when we implement threshold for completeness. This will be the field that we will take into account for these patients. So the form would still be marked as complete as long as this field is answered for emergent salvage, and urgent patients, no family available, and frailty question was unable to be answered prior to discharge. So still complete this field, even if the patient's not able to complete the questionnaire prior to discharge. All right, next question. Indicate which of the following activities the patient needs any help with from another person. Select all that apply. Melinda.
Okay, so we changed this one based on you guys' feedback. And so now you are to indicate the items below that the patient needs any assistance with to complete. Okay, so we took out that whole phrase about exclude activities the patient was never able to do before. That's gone from this next question, sequence number 7. It's gone. It's not there anymore. So if you have a patient that cannot perform any of these activities independently, or they're dependent on an assistive device to perform the activity, or they have to have another person help them perform the activity, then you would check all of the activities that apply. If the patient's completely independent and they can do everything and they don't need any help, just put patient does not need any help.
And I just want to clarify on that, Melinda, a patient, so if we're talking about walking around and the patient carries around a cane just because they want to feel safe, maybe have some balance issues just to protect them, but the patient's able to walk around without help from another person, they're only using the cane as a supportive device, they don't necessarily require it. That's different than somebody who is dependent on the cane to provide them support. So
Yeah, or
okay.
Yeah, they have to be dependent on the assistive device. So like somebody that's wheelchair bound, you know, they're in a wheelchair, they can't get up and walk around, they're wheelchair bound. They're dependent on that assistive device to move around.
Right. Okay. And I know there's some questions. Maybe we should take these.
Some of these questions, yeah,
Yeah,
before we
specific
get
to
too
this
far
one.
in.
So I'm gonna take, Hannah, I'll take your question from, that you just submitted about define walking around outside of the house, shopping, et cetera, or just around the home. Melinda?
Just walking, Hannah.
Yeah, just walking in general. It's not specific to if the patient can go out and, you know, spend 2 hours in Walmart walking up and down the aisles. It's more about the ability for their everyday walking needs, right?
Yeah, can they walk independently?
When they get up in the morning, are they requiring any assistance with walking? Oops. Can you add that into the question statement, including independent on assistive devices? And I think, Melinda, you had that, you added that in.
It's in the training manual. It's in the training manual, you guys. We
Okay.
can't put everything on this data collection form, but it's in the training manual.
Yeah, thank you. I feel like I've been in the dark with this. I missed that this is due on April 1st. We had a few cases in April to date. So Lisa, actually the date on the top is not correct. We haven't gone live with this yet. We're presenting the form following feedback that we received on the March 20th call webinar. So we're not quite live with this yet. We'll send out official notification via email when we do go live with this. What about intermittent restrictions? Clarify, Hannah, I'm not sure what you mean by that. Is the expectation to complete the Frailty DCF for every procedure type? Yeah, so we'll talk more about that, Priya. Let's get through the questions specific to this first question that we're on. Independent use of a walker is not needing assistance of a person. How do we code? So without that walker, the patient would need assistance from a person. So I think you have to look at it that way. And we'll put clarifying language in the training manual. The same thing with wheelchair bound patients for patients who might have bilateral amputations, bilateral lower amputations. They would not be able to get around without the assistance of a person. And I don't know why every time my questions keep on moving, so I apologize. And then, okay, I'm gonna move on because I think we got them all. I think we should add a statement about patients using assistive devices. These people who are filling out the forms may not have quick access to the training manual. Yes, sir. So that goes along with the clinical screening forms or clinical worksheets that we were talking about earlier, to where we're going to have more specific information on that form. So when the clinicians are filling out the form, that information is right there for them. So we'll have two forms. This is the Frailty data collection form. This is the data collection form that you'll be entering into REDCap. These are the questions that will be in REDCap that you'll be answering. And then we'll have another form that's more focused towards the bedside or clinician screening of the patient that will have some helper text in there. All right. Indicate which of the following activities the patient needs any help with from another person. So this is another ADL question. Melinda, do you want to go through that one?
Yeah, that one didn't change at all. That is exactly the same that we described prior calls. So this is, we're indicating which of the following activities the patient needs any help with from another person. However, on this particular question, we do exclude activities that the patient is capable of performing, but they never had to. So like if a lady has never had to pay bills or write checks or do nothing like that, you would exclude that activity because she never did it. Her husband always did it. Okay. So this field has not changed at all from our prior presentations.
Thank you. Indicate if the patient has problems with logical reasoning or memory cognition.
This one has not changed at all either. The thing here is that this is a perspective from a clinician's perspective or the family, you know, if the because if you've got a patient that's like moderately impaired, they're probably don't know they're moderately impaired or severely impaired. So when when this question's being answered, it's from a clinical perspective. It's also from a family perspective. If their family tells you, well, you know, they forget where they're going or they leave stuff off, they can't remember anything anymore and things like that. And we have descriptions in the training manual about what is mild impairment and what is moderate or severe impairment. So that is how that question is answered.
Thank you, Melinda. Indicate how the patient rates their own health from the patient's perspective.
And this is the patient's perspective. So, and this hasn't changed. We didn't make any changes on this. So you basically ask the patient, what's your perception of your own health? How would you rate your own health? And let them tell you, based on the choices from excellent all the way through poor, where they think their health is.
Thank you. And then indicate in a typical week how often the patient feels that everything they do is an effort.
Yeah, nothing changed on this one too. This is, we didn't make any changes on this. Basically, you're asking the patient, how many times a week do they feel like everything they do is an effort, meaning that it's difficult to do or it's tiring to do, and you let them answer that question for you and fill out their response.
And then indicate in a typical week how often the patient engages in moderate or strenuous sports or recreational activities.
Okay, we didn't make any changes to this one. It's the same that we've been teaching on. And again, the patient will tell you, or a family member will tell you if the patient is not able to answer questions. And when we talk about moderate or strenuous activities, these are activities that will elevate your heart rate, cause you to sweat. You know, so we have some activities described in the training manual, such as, you know, dancing or pickleball, jogging, swimming, cycling. But, you know, those are just examples of activities. I'm sure there are other activities. Somebody mentioned horseback riding, the last call, that would cause somebody to work up quite a sweat and elevate their heart rate. So again, we have some examples, but again, you can ask your patient those questions or the family those questions.
Thank you. And then chair rises. So we're only doing chair rises on elective cases. We added a parent in here. The patient was elective status, yes or no. If the patient was elective status, then indicate if the 5-time chair rise evaluation was performed. If it was performed, or the choices are completed, attempted, the patient was unable to complete per instructions, or chair rise evaluation was not performed. If it was completed, record the time in seconds for the patient to do 5-time chair rises. And then if the chair rise was not performed, so this last choice here, provide the reason why the chair rise were not performed. So it would be a free text field. So this is changed a little bit into that we're collecting the exact seconds and we're going out to the hundredths with this. So it could be 13.59 seconds. We could enter that in here. And then if the chair rises were not performed, then you'll free text in the reason why it was not performed. And that's it. Go ahead, yeah, and go on and walk through those, Melinda.
Well, again, we added patient was elective status. So the chair rises just for elective status patients. Okay, those are only the patients that you have to do this on. So if you have an urgent, emergent, salvage patient, then you would say no to this question. Was the patient elective? And all the child fields below would gray out. Okay. if you have an elective status patient, you say yes. And then you're going to indicate the evaluation, whether it was performed, and completed means it was completed. They were able to do the 5-chair rises. Okay? Attempted, but they weren't unable to complete. So this is somebody who tried to do it, but maybe they couldn't do it 5 times, or maybe they couldn't do it without using, they had to use their arms. So they just couldn't do it per the instructions. And then we have the chair rise evaluation was not performed. So these are can be any type of reason it wasn't performed. The patient may refuse to perform it. Okay, it wasn't performed. You may not have enough staff to perform it. It wasn't performed. Okay, so it could be a number of reasons that chair rise evaluation was not performed. If it was not performed, then we have a free text field down here under number 140 where you can write the reason in why it wasn't performed. And that will provide us with some good feedback so that we will know the reasons why the chair rise evaluation was not performed.
Thanks, Melinda. All right. You want to go over to the questions now?
Yeah.
Right.
And then we can, we should do the questions, and then we can, yeah, let's do the questions.
Yeah, because some of these, I think you want to share the training manual. Some of the language in there is going to help at the beginning answer some of these questions. Hannah's asking if you could send the clinical screening worksheets and training manual before the surgeon webinar. Yeah, that's the plan, Hannah. So in that notification that we're sending out to surgeons and sites, we plan to include a link to the data collection form, the clinical worksheet, the training manual, the clinical training manual, or flyers that we put together, other supportive educational material for bedside, and then also put in the webinar date with a link to the webinar. So everything's in one spot, one email, and then it's all available before you have the, I'm sorry, the questions keep on going down to the bottom, so I have to keep scrolling up. So you all have it before the webinar.
Carol, can I just add one comment about Hannah's last comment? That we're not giving you enough time to develop these things. And I just want to say that this is a soft start date. You've got until January the 1st of 2025 to get everything in place. So we're working through this together. You guys are helping us. We're all learning together and doing this together. And so don't feel like you have to immediately put this in place if you're not ready yet. Okay, you've got until January the 25th to get all your ducks in a row.
Yeah, January 2025. So hopefully that's enough time. And we're going to work through this together. I think we're going to learn a lot about doing this type of assessment at sites, and I think we're going to be able to help each other out, sharing tips and tricks about how you found it to be the easiest or most successful way to implement it, and then sharing that with your colleagues on these calls. I think that's a good idea, Melinda, right? I think we're all going to learn. I don't think we've ever really done anything like this before, so.
Absolutely.
These types of questions. So it's going to be a learning process for everybody, but don't feel stressed. We'll get through it. All right. Is the form available on for the STS site? Not yet. We'll have it posted. I did post a note up on the STS site though, that says, see, I have to log in too. Would you and we did add this access to Intermax button, so that's nice. But for ACSD, when you go to the adult cardiac information and access data collection resources, the frailty information will be posted here, probably within 4.20 or right above it. But I added this in last week, March 28th, that frailty data collection resources coming soon, currently delayed as of March 28th, 2024. So it's posted on the website there, and it will be updated as we get the information posted. So you'll see that. 2 questions from Ala. Can nurse practitioners and PAs attend the webinars with surgeons? They will most likely be the ones collecting the data. And I don't know why every time somebody enters in a question, it scrolls down, and I apologize because it kind of stops me from doing this. So I'm gonna.
It happens to me too, Carol. That same
I know,
thing's
it used to
happening on
not
our
do
end.
that. It drives me crazy. All right, sorry, everybody. So yes, anybody can attend that webinar. You all can, the data managers, the practitioners, the medical assistants, the PAs, whoever you think will be doing these screenings, it's highly recommended that they attend, or somebody on your team attends that can pass along the information. The webinar will be recorded, so that kind of, typically what has happened with evening webinars that are aimed at the clinical staff is that they're not well attended, because everybody is so busy or finishing up their days and the time zones don't work, or there, emergencies in the OR, things like that. So these will be recorded, and we'll of course post it on the YouTube channel, but I think we'll probably send out another webinar with information regarding, or I'm sorry, we'll send out another email with information on status update on the Frailty project, and then with this training webinar link included. So we'll do our best to get it out to as many folks as we can. Crystal's asking, will the Frailty data be part of the risk adjustment? Yes, in the future, the plan is that Frailty will be included in the risk adjustment. What are the intent of this collection? It's to better understand how Frailty impacts the outcomes of cardiac surgery patients. We don't have any hard data linking that, although there are quite a few studies out there that strongly suggest there's a large correlation between Frailty and surgical outcomes. This will give us more objective data to use and consider for future risk adjustment. Currently, the data will only be entered into REDCap. We are working with vendors who are able to provide this additional format. Some vendors are not built up to enter in these this type of additional form into their data collection for sites, but those that are working with us to allow sites a second or a supplemental way of entering in this data outside of using the REDCap form. Is patient ID and record ID the same? No, Bonnie, they're 2 different IDs. One is the patient ID will start with a V and the record ID will start with a V. The patient ID is the overall patient ID. So when you enter in a new patient into your vendor software, your vendor's going to assign that patient an ID, a patient ID. It'll start with a V. When that patient has procedures, each procedure is assigned a record ID. So you could have one patient that could have multiple record IDs. The record ID, they're all going to be different. So record ID, patient ID are different. However, they both start with a V. Patients only get one patient ID, but can have multiple record IDs. So I hope that helps.
And Carol, can I add in, there are situations, especially if you're new to using a vendor or something like that, where the value of the patient ID might be the same as the value of the record ID. That's usually pretty rare, but it can happen.
Okay.
But just know that they are different values.
Okay, thank you.
They have different meanings, yeah.
Okay. Hannah's saying this is making making abstraction more time consuming, having to transcribe these 3 IDs. Well, Hannah, I hope what I would do if I were abstracting this, I'm not abstracting it, but if I were, I had my vendor software open, my EHR open on my other screen. I have the REDCap form open. I go ahead and get my patient entered into my vendor software. Right away, it's going to populate, and you get that procedure added into your vendor software under the patient ID. You're going to, you should have your participant ID somewhere there, but you should know it. It's 5 digits, starting with a 1 or a 3. And then within your vendor software, you could just copy and paste right into REDCap the patient ID and the record ID. So that's exactly what I would do. And just make sure you copy and paste them into the right spots, so they don't get confused. Now, for vendors who are, who have the functionality to build this for STS and for their sites, these 4 fields, the participant ID, record ID, patient ID, and date of surgery will automatically transfer over into the vendor software, so you wouldn't have to copy and paste them. So they would be right there. I use ARMIS and there's, I use ARMIS and there's only 1 V number. There should be 2 V numbers, Desiree. Paul, do you know anything about ARMIS?
I do. There's 2
yeah,
V numbers.
Yeah, they're certified that there's 2 of them. You might need to ask your vendor how to identify it, but they're there.
Okay, thank you. On direct data entry, it says record ID is just the last 4 digits of the patient identifier. So patient ID is 4V60 1234. Record ID is 1234. Is this not correct? I think there's a couple different identifiers on the direct data entry. 2 of those are IQVIA identifiers, and then 2 of them are STS identifiers. So I may need to work with IQVIA. Amy, if you want to send the STS help desk an email, we can get that clarified for you. STSDB_helpdesk@sts.org. Would it make sense to add a V in the record ID to prevent confusion? So V's are going to be in both the record and the patient identifier. And I think we have some helper text on the REDCap form that will, is that what I saw go across it through some emails between everybody and
Paul,
Nikki?
Yeah, Paul, didn't we do that? Didn't Vicky?
Yes. Yeah, we added it to the, I think to all of the forms that it tells you that this value should start with a V. And one thing to be careful of is when you're using vendor software, you want to look for a value that has a V in front of it. You might have other values in there that say record ID, patient identifier, something along those lines. But there should be a field there that has a V and a number after it. And that is your record identifier and your patient identifier. Don't just stick a V in front of like some other field. That's not helping the matter any.
Thanks, Paul.
Mm-hmm.
If a patient is elective but the frailty is missed prior to the procedure, can it be completed post-operatively and hold the chair rises and we still get credit?
No.
I don't, yeah,
No.
I'm not, oh, thanks, I'm not sure exactly that will work.
Yeah, we discussed that. That's where the surgeons drew the line. Elective patients need to have this done pre-op.
Both of them, right? They need to have both of them.
Both of them. Yep.
Yeah. And I don't know what the completion threshold is going to look like yet for frailty cases. For mortality, we started off with a much lower threshold than 98%, and we built up to 98% over the course of a few years, just to give sites, time to onboard the completion process and make sure everybody had something in place to get the data completed. So we might do something like that. More information will come on that, Brandy, as we start getting data in and doing analysis with it. Is this data being entered somewhere separately and not part of the regular data entry? This will be entered into REDCap, unless the vendor that you have is able to build the form into their vendor software. They have to have the functionality available for them to do that. So right now, it will be entered into REDCap.
Yeah, until we have the next upgrade, and then we would incorporate it in. Correct, Carol?
Right.
Yeah.
What if patient refuses? Yep.
If the patient refuses to answer the question, so first of all, let's talk about the questionnaire. These questions. And then we'll talk about the chair rise. So first of all, it's expected that the questions will be answered either by a family member or the patient. If both the family member or the caretaker or the patient representative or the patient, if they all say we're not answering the question, then leave the question blank and move on to the next question. Okay, so then we go to the chair rise evaluation. If the patient refuses to do the chair rise, put chair rise evaluation was not performed, and then go down to your free text field, sequence 140, and say patient refused.
Thanks.
Hopefully that answers that question for Hannah.
Thanks. I hope so. The people who are using incorrect patient or record number, have they been notified? So if you haven't heard anything, you are good. I don't know that we reached out to people, Paul.
Is he there?
I think he's here.
I'm sorry, I get distracted. What was the question?
People who are using incorrect patient or record number, have they been notified?
No, we're not going to tell you. Yeah.
Well, I think we haven't even really analyzed the beta blocker data. We haven't really even looked
No,
at
we
it yet.
haven't.
It's only,
No.
yeah, we've only been collecting it, what, for 3 months? January, February, March.
Yeah, no, I wouldn't assume that you're good. If you're concerned that you've used the wrong identifier, send an email to help desk, STSDB_help desk at sts.org.
Thanks, Paul.
Mm-hmm.
In regards to the record ID, I'm working on a case right now in IQVIA. There's no V number in front of the IQVIA record ID or IQVIA patient ID. So I think Paul just answered this. There should be another number, Corey, that starts with a V. It's not the IQVIA record or patient ID. There's a V number there.
Yeah, I gotta check with IQVIA to see. I actually don't know what it looks like on the data entry screen, so I'll have to check with them.
Okay, if you could get a screenshot, Paul, we could add that into the training manual too.
Okay, yep.
Let's see what that looks like. Otherwise, Corey, you can reach out to the help desk, STSDB_help desk at sts.org. It's in the chat box to get more information on that. I'm going to have to put a complaint into Zoom because this is driving me crazy. In HeartBase, only the record ID starts with a V, the patient ID does not. So I would verify that, Sheila, with HeartBase and see which number you should be using, or which number is the STS patient ID. It is supposed to start with a V. This information regarding record ID and patient ID is within the software specifications that we send to vendors and what we use to certify vendors when they go through the version upgrade process. So this is it's not something new. It's something that vendors are aware of, and they know that it starts with a V, and they've been certified on both of these fields. We certified that both of these fields start with a V when they do it with us. Well, the clinical form match just the top will have MRN and not patient ID. So let me
well, no, and it doesn't need to match, Carly, because one is a clinical form, and that is so that the clinicians can enter that data on the patient using their medical record number. So you know who the patient is, and that gets in the right chart if you're going to put it in your chart. And the patient ID, or the STS patient ID and the STS record ID, have to do with you as the data manager entering the form into REDCap. And the reason it's so important that we get the STS ID and the STS record ID is so that we can link the REDCap forms with the regular STS data collection form that you've done on this patient on the index procedure. We have to have some linkage to link the REDCap with the STS data collection form. So that would be the STS record ID and the STS patient ID.
So this is the clinical screening form. This is a draft that we're working through. And like I said, there'll be helper text on here. We try to limit this to 2 pages. So if you need to print it, it can go front and back. But for scanning in, I know it's hard to scan in double-sided. So this is what the form will look like. The questions are going to be worded for the clinician to ask them. So indicate which of the following activities you need any help with from another person. Specific towards the question, specific towards the patient. And then I think we're also working on, we provide some ideas about what strenuous activity is, what to exclude, like regular paced walking, that do not elevate the heart rate. And then for the chair rises, we have some kind of a poster cut out here that we added in. We hope to find an instructional video to add in, or have one developed for STS that can be added here. And then specifics about how to perform the chair rises. And then we added in a clinician signature and date in case you do want to scan this into your chart. You can do that. They can do that here and just make it part of the chart from the preoperative screening phase. So this is still a work in progress, but we're working on it. All right, I know we're getting close on time. Let's see. If a patient, I'm going to try to go through these as quick as possible. If the patient ate the bedsides.
Oh, I get this one. So basically the same as what Carly was asking. The person at the bedside who's performing the assessment does not need to know the record ID or the STS ID. Only the person entered into REDCap needs to know that. So on that worksheet that Carol was just showing you, you would enter this, whatever identification, your medical record number or whatever you use for the patient name, you would enter this just like you normally would any other document in your medical record. That's why we don't have the record ID here or the patient ID here for STS, because we don't need this here. We need that for the REDCap form.
Thanks, Melinda. Is this the form the physicians will use to ask the questions? If so, they are going. Okay, that's the same. If the frailty assessment is not included in the risk model or threshold isn't applied, what can we use to ensure the assessment is completed on every patient? It eventually will be included, Molly. So you're gonna have to help with education at your site for your surgeons and heart team to complete this form. IQVIA record ID for patient does not start with V, only the patient ID. Yeah, the patient ID and record ID must start with a V, Heather. So Paul's going to look into that with the IQVIA direct data entry. But you can email stsdb_helpdesk@sts.org. Sorry, Banu and Paul, for sending out so many emails to you. Patient ID is under patient forms, and the record ID is under the episodes. Thank you, Dee, for Armis.
Yeah, and I would recommend, before you send a message to help desk saying, where is it? We don't know where it is in your vendor software. Check with your vendor first. Yeah. And then get in touch with us, because we can't tell you what your vendor software looks like. We have no idea.
Thanks, Paul. We don't know what your vendor software looks like. We only know what it looks like when they send it over to us to test. We don't see your platform. We don't know what the platform looks like. So is there a way to find out if your site's been incorrectly submitting REDCap beta blocker data? Paul, you want them to reach out to the help desk?
Yeah, just send, if you suspect that you've done it wrong, send an email to help desk.
stsdb_helpdesk@sts.org. Sorry, Banu and Paul, for all the emails you're about to get. I'm going to say it every time.
Happy to help.
Okay. You'll learn.
Knew I shouldn't have attended this meeting.
Oh, we'll still give out your email. Don't worry. Is the expectation to complete the frailty DCF for every procedure type? So let me show you.
I can answer. Well, what we decided, working with the surgeons, is the required entry cases have to have this done. So
what are required entry cases, Melissa?
Yeah, so we're going to go to the required entry case list.
Right. So I'm under the 4 data research and data, 4 data managers, under adult cardiac, access data collection resources. This screen pops up whenever you open this for some reason. So you just got to move your mouse around to get out of it. And then under version 4.20, scroll down just a little bit to additional resources. And this right here, case inclusion guide. So Melinda, tell me about this form.
So We'll start at the beginning.
Let me scroll up.
So we have this inclusion document. So these cases are required. Cabbage, valve, and any type of valve repair or replacement, whether it be aortic, mitral, tricuspid, and we're talking surgical valves. We're not talking TAVRs, they're optional. MAVRs, they're optional. Okay, any of those clip kind of procedures, they go into the NCDR. They don't have to go into our database. So next, scroll down a little bit further. And then any aorta procedure starting above the diaphragm. So that's arch procedures, ascendings, descendings, roots, TVARs, if it's a CT surgeon participates in any part of the case. And then we got any other kinds of procedures on the heart or the aorta. So LV, RV repairs, cardiac trauma, aneurysm repairs, ASDs, VSDs, subaortic stenosis, you know, most of the stuff you guys are real familiar with what you're required to enter into the database. AFib cases done by cardiothoracic surgeon, mazes, clips,
And these are
ablations.
standalone mazes, right, Melinda? These are not cases. It
Yeah.
doesn't matter if the maze procedure is done in conjunction with a CAB or an AVR, or if it's done all by itself. It's still, if a maze procedure is done, it's going in the database by a cardiac surgeon on your agreement.
Correct. ICD and pacemaker lead extractions done by CTS, cardiac surgeons, they're required entry. They'll need this. And then we'll just go down to the patients that won't need this now. So down below, you'll see we've got all these optional cases. So these are the patients that won't need the Frailty. Standalone ECMO, Impella, VAD, artificial hearts. They're standalone procedures. They don't need it. We don't enter those patients in. They're optional. TAVRs, MAVRs, mitral clips, tricuspid clips, any kind of those valve transcatheter interventions. Those are optional cases to enter. They don't need this stuff done to them. Standalone angiovac cases. We don't enter those in. They're not required to be entered, so they don't need Frailty. And what else, Carol? Slide down just a little bit. Standalone pericardial windows, pacemakers, ICD insertions, lead insertions, they're optional. They don't need it. Lung transplants don't need it. Heart transplants, they're optional to be entered into our database, so we will not be required to do Frailty.
Thank
now,
you, Melinda.
I know this list is going to be hard to get it across to your providers. And a lot of these cases, you know, like a lot of these won't be elective cases either. So like, you know, an LV repair or an RV repair, that's generally not going to be, an elective case. An aortic dissection is generally not an elective case. So some of these are going to be, or a lot of these are going to be urgent or emergent salvage cases where you will not have to do the chair rise evaluation, but you'll have to do the questionnaire sometime before discharge if the patient or the family is able to answer the questions.
Thank you, Melinda.
Okay, hopefully that helps.
All right, so there's some comments in here about the language on the clinical screening form. Now, remember that this is going to be, you're not just gonna, this form isn't just gonna be handed to the patient. Patient fills it out and hands it back to you. The clinician has to engage with the patient and ask these questions. So when we talk about the wording of these questions being at a specific level for the patient, the surgeon's going to have to ask which of the following activities you need any help with from another person. However, we have to be careful with changing wording because this is what do you call it, like a verified form or something. It's the Rockwell screening, a clinical frailty screening form. So we have to be careful, or based off of that form. So we have to be careful with changing wording, which could unintentionally change the meaning of the question. So just be mindful of that when making, if you make any suggestions to change the form, I guess. All right, unfortunately we have 87 questions or comments. And I have another call right now. So,
Carol, can I jump in before
Okay.
everybody gets off? Somebody just sent me a screenshot of the IQVIA platform for people doing direct data entry, and patient ID and record ID are there with the V number before it.
Can you want to share your
Can you
screen?
share it?
Paul?
Yeah, let me do it in a way that I can cover everything else up. Hold on just a second.
Okay.
Well, it's not going to show much because it's only a screenshot of the IDs. It's not really telling you much of anything.
Okay.
But it is in there, and it's labeled patient ID and record ID. So
Okay.
it's there.
Thank you.
Mm-hmm.
All right. Well, I guess we do have quite a few more comments we can go through together after the call, Melinda.
Mm-hmm.
Some feedback we might want to add into the training manual. I think one of the themes I'm seeing is about what if patients refuse to complete this. I think it's part of our responsibility to educate on the importance of this, and getting the patient to complete this screening, I think, is important to understanding how that patient's going to do after surgery as well. So not having this information that is not going to help the patient do better after surgery, right? It can help identify areas that you can optimize the patient preoperatively, right? To allow them an opportunity to have a better outcome following surgery, or to get back on their feet quicker if you address the frailty status, if there is anything that can be addressed with patient optimization. So I think understanding it from that perspective and not just another form that we have to fill out might be helpful for the patient and for the clinician performing the screening to understand. And anything other specific that you want to cover?
Well, I keep seeing the theme about who's going to train people to do this and how's that going to be done. And data managers, some of them are remote, they can't do this. And I think that, we are giving you guys the information, and we're also going to be having a surgeon webinar. We also know that this information was presented at the surgeon national meeting, so I suspect that surgeons are aware that this is coming. And if they're not, it's part of us and you guys to at least make them aware that this is coming. And we are going to be trying to provide, like I said, we have to get the worksheet completed. We need to get some resources about, just how to do the chair rise. Maybe a good video. The surgeons haven't approved that yet. I was also thinking of maybe a flyer, that could just, this is how you do it. These are the steps for doing it, and things like that. So this is sort of kind of a work in progress. I mean, we're working as hard as we can to get these things done. But as Carol said earlier, we're all doing this together. So your feedback has been very helpful to us, and we really appreciate it.
Yeah, thank you. Thanks, Melinda. I agree with that. But lots of other questions are coming in about patient ID and record ID being the same in IQVIA. And I think for some of those they start with the B and they're the same number, patient ID and record ID, but as the more records get added underneath that patient, they should change.
Right.
right? Is that right, Paul?
Yeah, that's right. Especially in adult, it's likely that they could be the same value,
Yeah.
but they have different meanings, and you can't count on them being the same value. They're more likely to not be the same value. And
And
actually, for IQVIA, it'll actually start with V60. So just to give you a hint of, yeah.
and what's Cedar on 59?
I could tell you in a second.
Maybe we should post that in the training manual so sites know, so they know what to look for, because each vendor is assigned a vendor number.
Right.
So direct data entry is 60. V60 will be IQVIA, and I think Paul will look for Cedar on. I think there's
CEDAR is 59.
59. So all Cedar, and if you have Cedar on, you'll look for a number. It starts with V59.
V59. Yep.
Yeah, and
Yeah,
then
I need that information. That would be helpful to like
yeah.
have some visual for them.
Okay. Well, the V
Yeah.
should be a dead giveaway.
Well, V, yeah, I know. It would be
All right. Well, thanks everybody for joining.